Hello and welcome back to Temple's YouTube page. Today we're going to be doing a short video on the Therapeutic Paracentesis, tricks for treating the pregnant man. So in ERs across the country we see patients with bellies like this. It could be a man, it could be a woman, don't want to be sexist here, but when it's a man we know that it's not a baby in there. We're dealing with the ascites fluid from cirrhosis and the abdominal distension that accompanies that. So we're going to be going over quickly some of the indications, contraindications, etc. But really what we want to show you today is a trick for performing a large volume paracentesis with relative ease. Let's go. Alright, so indications to do a large volume para. There really are two. One of the more common ones is respiratory compromise. As the abdomen grows and distends and the ascites fluid occupies space, you develop a restrictive physiology of your lungs and have a difficult time breathing, become dyspneic, short of breath. Coupling that with sometimes having the translocation of the ascites fluid into the chest wall, or chest cavity, you can get pretty uncomfortable with this, and that's one indication to try and take some fluid off. Another one is the abdominal pain. So the distension that comes with this can be pretty uncomfortable for patients and interfere with their quality of life pretty significantly. So removing the fluid can also decrease the discomfort that comes with this. The contraindications, looking kind of at Medscape's general outline here. So the line between a absolute and a relative contraindication kind of blurs here. But one of the things they mention is an acute abdomen or surgical abdomen where you really need a scalpel and not a needle. We don't want to be doing therapeutic paracentesis if someone really needs the operative suite. As always, having cellulitis at a site of a needle puncture, whether it be a knee or a belly, is never a good idea. We don't want to be introducing bacteria into a joint, into an abdominal wall, or any area of the body. We don't want to be spreading infection. And then finally, major coagulopathy. So Medscape itself cites this as being kind of platelets less than 20,000 as the number they use, in INR greater than 2. UpToDate adds in or mentions DIC as a contraindication. This is a bit of a hot topic. Collectively, there's mounting evidence that having labs to screen for these things before doing a paracentesis are generally unnecessary if patient has not had major coagulopathy or thrombocytopenia in the past. Outside of a new acute process, obviously, as mentioned by UpToDate, a new DIC, we sort of need to reconsider this. And this is supported by the literature. Here are a couple quick articles that I glanced at for preparing for this talk. And really what the major thing to hang your hat on or to cite when knowing that you don't have to do screening labs would be this group here. So the American Association for the Study of Liver Disease creates practice guidelines, and they updated them in 2012 and discussed this and talk about how screening labs are generally unnecessary, and more specifically, giving FFP or platelets for abnormal labs is generally contraindicated because of the very low risk for major bleeding from doing this procedure. So that's a group worth knowing about and citing when you do this process. All right, so generally the approach, we are going to be approaching this in the lower quadrants, right? Upper quadrants, you got your liver. You got a lot of your solid organs up here that you don't want to poke or stab. So lower abdomen, and really the left lower quadrant is definitely cited as the preferred site. In our patients with cirrhosis, sometimes hepatomegaly can bring the liver tip down into the right lower quadrant and cause problems. So we're going to go in the left lower. It's pretty safe down there. We want to aim for the lateral aspect so that we avoid the inferior and superior epigastric vessels as well. Sticking our needle in right there. And for this tap, you'll notice that we used a preset kit that's found in our Department of Paracentesis kit. I have attempted this in jerry-rigs with other types of access things, with angiocaths, etc., and had less success because the catheter, again, it'll have a single hole, which puts most of the pressure and volume through a single port, where these kits will have multiple fenestrations and multiple holes, allowing you to pull larger volume without creating a single point of pressure in the abdomen. And also, this is much more pliable than an angiocath, which has kinked on me in the past and disrupted this process. All right, so our guy, Obviously, we went through the due processes that you won't see in the video footage here. Got a consent from our gentleman. We used ultrasound to guide our landmarks to make sure we had a good layer of ascites fluid between the abdominal wall and the viscous organs that are floating in there. And we used sterile technique to try and prevent any infection or complications from the procedure. And the part of the trick for this video, the thing that we want to show you, is that we were able to do this large volume para with the assistance of wall suction. And I'm going to outline the way that we were able to connect our paracentesis kit to wall suction to make this much easier for ourselves. So this is an up-close view of how we did it. We have our para kit, which hooks into a general syringe. We used a 3cc syringe. We pulled the stopper out of it and hooked the football from the wall suction into that. We used a rubber band to help improve the seal there that we sterilized, obviously, best we could before connecting it to the patient. So this is a means of getting your para kit hooked to wall suction through the use of a syringe. Another way to do it would be to use a 5cc syringe, which connects directly to the rubber or plastic part before the connection of the football. This is basically the end of your suction tubing plugs right into the back of a 5cc syringe if you remove the plunger. We found that this created a slightly less strong seal or suction, so we opted to use this so that we can maintain our flow. But this is probably a little bit prettier and a little cleaner. These can connect right into your para needle. Okay, so let's go into what we did, what it looked like. So this is our guy. Before we show you the live footage, this is kind of the setup that you'll see there. Left lateral part of his abdomen, we used the para kit and the multiple hole para catheter, and the blue end of that hooks right into our syringe, which is connected to wall suction. Let's see what that looks like live. Therapeutic tap, jerry rig to wall suction. Was that a 3cc syringe? With good flow. Let's see, he probably could take more.
How are you feeling?
Great.
Breathing better?
Yes.
All right, that's it. That's how we did it. That's how we were able to get large volume off of this gentleman in a matter of minutes, where oftentimes, if you're using a push-pull method or just taking off syringes and syringes of fluid or using vacutainers, it can take forever. But we were able to get 10 vacutainers off of this gentleman, again, in the matter of minutes. Much easier to do, less time intensive, less staff intensive. A couple points to remember or to discuss. When our gentleman came in, he had just run out of his antihypertensive medicines a little while ago, so he had blood pressure and then some. He initially had systolics in the low 200s, so we were very confident that we were able to pull off volume from him without precipitating major hypotension, which is one of the problems that can come with large volume paras. This guy lived in the 170s, 180s, happened to not have his antihypertensives and was significantly elevated from that point, and we had a lot of room to work with. Secondly, there's always the consideration for the role of albumin in these patients when we're pulling off volumes of this order or of this magnitude. We don't want the oncotic pull or the lack thereof to allow fluid from the intravascular space to go right back into the abdomen, make them hypotense. So administering albumin, typically what's referenced is when you're pulling off volumes of greater than 5 or 6 liters, they recommend giving yourself a little intravascular push with this albumin. And finally, and as always, patient safety must always come first. It's always interesting and cool to be able to see yourself pull large volumes such as this off of a patient in a short period of time and to see their abdomen deflate and see them feel so much better. We always have to remember that we are doing this, one, for symptom relief for the patient, and we want to do it within the realm of safety for them. You may not always get volumes such as this off of a patient, But the hope is that this technique actually does improve patient safety, and it decreases the number of staff that need to be involved, decreases the time intensiveness of this procedure, keeping you out of other patients' rooms. So again, it may not be 10 vacutainers worth of fluid that you pull, but whatever is safe for the patient to have done that gives them symptom relief and does so in a short time frame is a win-win for us all. So hope you learned a lot from this procedure in this video. Please post any comments in the comments section. Thank you.